General practice is being pulled in every direction today, from urgent care, telehealth, aged care, to just traditional family medicine, and the cracks are showing.
There's a trend that a lot of GPs are looking for non-clinical work because they're finding clinical work too draining. Australia might not necessarily have a GP workforce shortage, but might have a distribution issue.
In this episode of Investing for Doctors podcast, I am joined by Dr. Daniel Lamp, a GP and also host of the Passive Income Doctor podcast, to unpack the real story behind the workforce exodus, funding chaos, and burnout that's reshaping modern general practice. We discuss the following: why GPs are going part-time or completely leaving the specialty, the rise of telehealth, urgent care, and corporate clinics, and what that means for patients and doctors alike, whether general practice is sustainable in the way it is right now, or if we need a full system reboot. And lastly, what a smarter and more modern day GP career might look like in the next 10 years. If you're an existing general practitioner or training to become a GP, this is a conversation that nobody is publicly having. What it means to be a GP is rapidly shifting. The old traditional models of general practice is not the same as what it's going to be today. It's not going to be what it's going to be in 20 years' time. Can general practice do it all? Hello, welcome to another installment of the Investing for Doctors podcast. I'm your host, Dr. B. And today we have Dr. Daniel Lamp back with us. Hi, Dan.
Hello, great to be here.
All right, so today we're going to talk about something slightly different. We're going to talk about general practice. Now, this is going to be very topical. So you're a GP. Why don't you give us a quick introduction about who you are, what you do, and sort of the portfolio career you've built in general practice?
Yeah. So my name's Dr. Dan. I run a podcast, Passive Income Doctor. I'm a portfolio GP, which is probably a term more used in the UK, but basically kind of rather than just having, one job full time, I have, multiple kind of roles ranging from, hospital, casual CMO work to traditional mainstream general practice, some casual urgent care shifts, and also some telehealth work as well. Yeah. So a broad variety.
Yeah. But all of that is quite clinical, isn't it? Yeah.
Yes.
Yeah.
Yes.
All right. So you've touched on a couple of things that you're doing as a GP, but let's go back into the beginning. So how did you become a GP? Why did you choose general practice? And do you think general practice is still a viable specialty, given all the noise around how general practice is broken?
Yes. Yeah, this is a very topical discussion in the forums and also in the media as well. So when I was in medical school, kind of, I guess, general practice, you get some exposure to it, but not too much. And I guess when I was, early stage in my medical career, PGY1, PGY2, considered a few different specialties such as critical care. And I ultimately kind of chose general practice for a variety of reasons. One is, when I did some work in the intensive care unit, seeing people at the sickest, and you do wonder, rather than trying to treat end stage disease, what happens if you could try and prevent it, diabetes, ischemic heart disease, hypertension, all these things, prevention, is cheaper and more cost effective than kind of that ICU care, for example. Absolutely. And another reason why I chose general practice is, I guess, just as doing 7 night shifts in a row, you can only do that for so much, and
it breaks you after a while.
It breaks you afterward. But shout out to all those doctors that do intense shift work. The health system relies on them. But for myself, I could see that I wanted less night shifts, for example, and also general practice. Whilst, for example, GP training itself might not be that flexible. Once I've become a GP fellow, you can kind of choose your hours, choose where you work, and it's quite flexible in that regards. And also, some other GPs I know, along with myself, it allows us to pursue passions outside medicine as well. Yeah,
like a podcast. Yeah. It's very difficult to do that as a full-time, registrar or hospital employed doctor, isn't it? So it sounds like that flexibility really sort of attracted you, and GP training is also a lot shorter than most specialty trainings. I guess at least back then it was not horrendously difficult to get on, was it?
Yeah. So GP training, I guess officially they call it 3 years, but 1 year is a hospital year, so you could say in effect 2 years, and there's some exams as well. But yes, compared to BPT training, and then after you go through BPT training, which is tough, then trying to get into a subspecialty or say surgical training, which can be 5-6 years, but then a lot of the times it takes multiple years to get onto the training program. So I guess GP in that regards allows you to become a autonomous or independent practitioner relatively sooner. Although obviously there's some people that do other specialty training and then change their mind, choose general practice as well. But then there's also some people that start off in general practice and find it's not for them. So I guess, medical specialties, there's actually so many options, which I wasn't aware when I was in high school or medical school. I think there's something for everyone.
Yeah. And do you think it was just that there was so little exposure during medical school and in the first sort of 2 years as an intern resident in New South Wales that?
I think there was some exposure. I went through University of Newcastle, which had a bit more focus on rural health. I did actually quite enjoy the rural GP terms as well. I guess though, once you start working in the hospital system as an intern resident, I think maybe Hornsby Hospital for a period of time had a GP kind of rotation, but in general, most places don't. So you're kind of not exposed to that. Or if you're exposed, there's a lot of certain people that might trash talk GPs, this GP has referred this patient into emergency again. So then you kind of get this negative
bad reputation
perception.
I want to tackle that because it's a selection bias. Right? What you see in hospital systems through emergency, through the acute services is where things go wrong. And that's a tiny minority of the patients that's seen through general practice every single day. And the majority of people never ever present to hospital. So you only see the bad cases and the disaster cases. You don't see the 99% that GPs keep away from the emergency department. So I just want to address that. And I think that is a cognitive bias that everyone listening should be aware about and not just trash talk each other's colleagues, because there's a humongous selection bias at play here. Yeah. So apologies to the for that, because I work in EDs and sometimes we do say that.
I think also as well, kind of every specialty, like any other profession, there will be kind of good practitioners and perhaps not so good or kind of maybe less experienced. There's a lot of GPs, for example, I'm not sure the exact percentage, but maybe 50% of GPs are, I think, IMGs, international medical graduates, and perhaps their system from the country they come from is different to the system here, and it might take a bit of time, or maybe there's other ways we could try and train and support them better.
Yeah, absolutely. Because there are other countries where they just get referred to a hospital and the hospital sorts it out, and that's understandable because that's the way they were trained in. Anyway, let's move beyond that. And so, how did you find your sort of GP journey and sort of post fellowship? You've built yourself a portfolio career. Why did you do that? And why did you not just go down to the single practice, work in a single practice, and that's it kind of model?
Yeah. So, GP training was challenging at times, especially the exams. Like any other exams, have to spend time studying for that one. So I did a mixture of city and also rural. So I actually did a 6-month rotation in Bathurst. I think the stream required you to do 6 months kind of in a rural setting. It's quite good. I think participated in an after hours on-call service. It wasn't too onerous, and also did a bit of nursing home work as well, which I think is probably a topic for another day. It can be quite challenging as well. And but I found, kind of on a personal note, towards the end of GP training, working 5.5 days to be quite draining, I think, mentally, and probably started seeing some symptoms of burnout, and I just, I'm glad, made it through. And I know actually some doctors, don't, they leave the training program, or, some leave clinical medicine, that sort of thing. But I was able to get through, and so I wanted to not just do mainstream general practice. I think it's also difficult talking to some older GPs. I think back in the day, people had less chronic disease, less burden of chronic disease, come in for one single issue, here's a script, or here's this thing, and and it's sorted, and you could probably easily sort that out in 5-6 minutes. But nowadays, with longer life expectancy and more chronic disease, and patients are time poor, often they might come in with multiple things that need addressing, and obviously as a GP you've got to try and, within the best you can in that, say 10-15 minutes, try to figure out what's the most urgent, what's the most important, sort it out. Is there anything I'm missing? Come up with a follow-up plan. And if you're doing that for 40-50 patients a day, for many days on end, I think
that's draining.
It can be quite difficult. So I think that's why I chose initially just to do part-time general practice,
as in mainstream general
practice.
And when we're talking about mainstream general practice, is basically sitting in a GP practice, patient comes to you, maybe 4 patients every hour kind of situation, and you do it for the whole day. Right? That's mainstream.
That's correct. Correct. And also I can touch on some of the other jobs as well. So like a telehealth job, for example, helping prescribe COVID antivirals during the height of the COVID boom. And then also more recently, it's kind of like a hospital in the home kind of setup, where kind of the nurses go out, for example, to give IV antibiotics for cellulitis, and then they take pictures, and the doctor can do video calls, phone calls, review the bloods, review the pictures, that sort of model. There's probably pros and cons of that model as well, but for a subset of patients, I think it's quite good for them, probably convenient as well, and
it keeps them out of the hospital.
Keeps them out of the hospital system, which very can be costly to the government, and also lack of hospital beds as well. And then also, do some casual shifts over the years, for example, in emergency or for urgent care, just to keep some of those acute skills, cannulation, venipuncture, suturing, that sort of thing.
So it sounds like you've built a very sort of clinical portfolio career in general practice, and you found the right balance that's sustainable for you. Because I agree, if you saw 40 patients every day, 5 days in a row, everyone's tired. Like, I don't even need to sort out their problems. Like meeting 40 people a day, every day for the rest of your life, that sounds draining, right? Back to one of my first questions. So do you still see, do you see general practice as something that's sustainable for the long term, or do you think there's a reckoning that's coming that needs to, basically we need to rework the entire system? Because I'll hear your thoughts, and then I'll share you my thoughts first afterwards. And what do you think?
That's a good question, whether GP is sustainable. I guess you could view it from 2 lenses, one from the GP side and then one from the patient or the general public side. I think from the GP side, it seems like there's a trend that a lot of GPs are moving to kind of part-time work, or, I know there's, creative careers in medicine, for example. A lot of doctors are looking for non-clinical work, because they're finding clinical work burden too draining. So I guess, whilst maybe the number of GPs is increasing, if the number of FTE, if the hours that the GPs are working decreasing, that's going to put strain in terms of patients accessing GP in a timely manner. But then, some GPs might be doing it as a self-preservation point of view. In terms from the patient side, it is interesting, right? Because obviously some patients will see value in having longitudinal care with one particular GP, kind of, they call it, cradle to grave medicine, that sort of thing. Having one GP that knows them well, some patients prefer, I only want to see that GP, for example, and that works well for them, especially that GP might know their past medical history, their allergies, the nuances, their social situation at home. But then other patients, like, obviously in modern environment, everyone's so busy, with work, some patients, some of the comments online or, talking to some of the patients, they're frank in terms of saying, taking time off work, say they're a plumber or accountant, lawyer, earning good money, having to come in the middle of the day during the work hours, wait in a waiting room, maybe the doctor's running late, waiting half an hour, 1 hour, so, and then have to pay a fee on top, a lot of GPs, for example, not bulk billing. So a lot of these subset of patients might prefer some of these online telehealth providers, that provide, say, a script or a medical certificate, or like a kind of niche or subspecialized area of medicine. So it's really hard to crystal gaze and see where the future holds. Perhaps there is a role for kind of the traditional GP clinic for a subset of patients, but then maybe there's a subset of patients that might want more telehealth, especially with COVID. Telehealth has become more mainstream and accepted.
Yeah.
And also as well, maybe like some of the other countries, maybe there might have to be some GP clinics that are government funded that can help the poorest or neediest of society. Yeah. I wonder what your thoughts are.
I think as a profession, like from the doctor's side, general practice has never been more attractive because that gives you a flexibility of whatever you do. You're not tied in with a particular hospital or at the whims of an operating list, for instance, if you're a surgeon.
Right.
I can guarantee you tomorrow that if you fellowed as a GP, you can pretty much walk into any clinic and say, hey, I want a full-time job. You'll get a full-time job. Right, that doesn't exist in the specialist space.
Right.
And I know a lot of colleagues who are in physicians, surgeons, critical care. The problem is not getting onto the program. The problem is getting off the program now. Right. And so the demand for GPs has never been higher. However, at the same time, the definition of what a GP is being very fragmented. You've got a portfolio career. You're doing office GP work. But then there's also the GPs that go into the nursing homes.
Yep.
There's also the GPs that are doing urgent care. There's also the GPs that are doing the telehealth clinics. There are also GPs in management.
Yeah.
Right?
And also skin cancer or cosmetics.
Cancer. Endless.
Yeah.
Right. And the problem is that all of these little factions are competing for the limited pool of general practitioners. So therefore, that's why there's so much demand for a GP. But at the same time, what it means to be a GP is rapidly shifting, right? And medicines are getting a lot more complex. Patients are getting older and older. And there's this demographic shift, right? The old traditional models of general practice is not the same as what it's going to be today. It's not going to be what it's going to be in 20 years' time. And so unless there can be this pivot towards a more flexible model of what it means to be general practice, I think there's going to be a lot of problems being generated just from a lack of bodies on the ground. I think that's the first thing. Look, the funding thing is like there's always going to be people who are willing to pay, people who are not willing to pay. Where I'm seeing is that there's a lot of sort of government incentives to keep things gap-free at point of service. I'm not going to say it's free healthcare because it's not free. It's being paid by tax dollars.
Yes.
Even the fully bulk billing clinics and the urgent care clinics, they're getting a lot of work. And I dare say there's a gradual shift from what urgent care is doing to what it was meant to do versus what it's doing right now. And I'll draw an analogy. I remember roughly about 10 years ago, maybe, there was a service called the National Home Doctor Service where you could get a doctor to go into your home to visit you and to see what's going on. And back then, they opened up that service to anyone who was, I think, PGY 3 and above. So not GPs, like, as in fellows of RSCGP or ACRIM. They could be a registrar and just trying to make some extra money on the side. That went very well until it went mainstream. And then everyone started using these sort of urgent services as convenient care.
Yep.
Right. I did a short period in that, and I saw the rapid decay in what it was once it went mainstream. I wonder I wonder whether sort of the urgent care model is also heading down that way, because the original narrative for urgent care was to support emergency departments and offloading fast-track patients from urgent care, even though I think ASEM, which is the College for Emergency Medicine, thought that was just not the problem that EDs faced. My understanding these days, and you can correct me if I'm wrong, is that urgent care is becoming increasingly convenient care because of the mass rollout of all of this. You've done urgent care for a while. I wonder what's your experience on the ground?
Yeah, so I guess my experience is, I think in the early days when it wasn't as well known, emergencies departments might send, say, someone that needed suturing or a plaster to urgent care, and there was more of that. And I guess, I think the
Costco's and stuff, still coming through, right?
Yeah. The initial idea I think is good in terms of offloading category 4s and 5s off emergency departments. But, me and some of the other urgent care doctors have noticed kind of a trend where, patients can't get into a GP the same day and they come to urgent care. And yes, urgent care might be open a bit later, outside office hours and, a variety of things that you could categorize as a GP presentation. A lot of them are coming to urgent care,
and that's no one to blame. It's natural, right? If you provide a service, and unless you're turning people away at the door, which they're probably not, because there's funding attached to seeing patients, so you're always going to get that sort of creep into the non-target demographics, much like National Home Doctors did.
Right.
And, when I started, 90% of it were urgent cases. Towards the end, it was maybe about 30% of them were actually urgent. The rest of it is just convenient care stuff. And you still had to go and you still service them. But, that collapsed on its own right for other reasons. But when you provide supply of doctors, you're going to get people who use it not the way it was intended. And it sounds like that's your experience.
Yeah, it will be very interesting to see what happens. Obviously, with the recent election, obviously the government has promised to open up even more. And what's interesting, I actually posted a reel on my Instagram, Passive Income Doctors, just showcasing a day in the life of a GP, where I did my GP work in the morning and then did urgent care. And the amount of comments was very interesting. Obviously, a lot of general public very like the idea of urgent care because they say it takes weeks to get into the GP, et cetera, et cetera. But then obviously, I think the recent study shows that, the cost per patient seen in urgent care is maybe 250 or 300 as per the RACGP.
It's like 4 to 5 times.
Yeah. While say a bulk billed level B standard consultation Medicare gives, $41.
Plus if you add the triple, bulk billing incentive, which the government's promised, that's
60
still
maybe.
60 something.
Yeah. Depending 70, on where you're metro, regional.
Yeah. So the cost of an urgent care visit, albeit it's after hours, it's still way more than a normal GP visit.
Yeah. And then obviously some people countered and saying, oh, hey, but then a visit to emergency departments, like, I know, I see so many numbers bandied around from $600 to $1,000. But I guess some of these numbers, it's hard to quantify, because obviously
it's average.
If it's an average, if patient numbers fluctuate, and also in an emergency department, like not every patient's going to cost the same, some will be high acuity. And it is also, I can see as well, can't recall which politician, on TV or social media saying, oh, if GPs just worked more hours, then our hospitals wouldn't be so full. So, oftentimes GPs are seen as a convenient scapegoat.
They're the punching bag for everything wrong in the system.
Realistically, talking to physicians who are working in the hospital system and also emergency doctors, a lot of the times the issue of bed block is not GP visits, because it's actually patients, waiting for nursing home or waiting for NDIS placement or, all these other social issues, which they might be in hospital for, 30, 60, 90 days. It is much more complex than just saying it's because GPs can't see patients or won't see patients.
Yeah, I absolutely agree. And the problem now is that when you're having this push into urgent care where you're easily getting double, triple, or even quadruple the amount of funding for it, you're pulling away GPs from actually bread and butter traditional general practice, such as yourself. If you didn't have urgent care as an option, perhaps you could be doing a bit more office type general practice. And so now we have these financial incentives to work outside of the existing model. And there's only so many people and so many hours in a day. So unless everyone starts working 60-hour days or weeks, you're basically robbing Peter to pay Paul in a way. Like, do you see some of your colleagues sort of doing a bit less traditional GP work and doing more urgent care work?
I think it depends, right? Obviously, some of these urgent care clinics, you have to work a set shift, which for some doctors who like flexible hours doesn't work for them. But definitely, I think, there's anytime there's a new policy or new announcement, there's always, unforeseen or unintended consequences.
The labor market.
And it will be interesting to see what the future holds.
Yeah. I mean, there is so many avenues where doctors can go in, but I just find that in general practice, and perhaps I'm going to get a lot of flack from the GPs for saying this, is that core general practice is really family medicine. It's, you might get some experience doing nursing homes. You might get some experience doing, hospital and home or hospital work. But by and large, the majority of the training is the traditional in the office family medicine. Is that what your experience has been? Or am I just completely...
Sorry, can you rephrase?
So the question is that general practice is still predominantly training. General practice training is still predominantly traditional office GP work, right? It's not all these other things that you're doing. It's not working in EDs, it's not working in urgent care, it's not working in nursing homes.
Yep.
But we're still expecting GPs to cover all of that.
Yeah, I think majority. It depends where, but majority of GP training, is in a GP clinic office-based environment. And yes, some GP clinics do offer visits to nursing homes, whilst a lot don't. And also home visits. I don't recall doing any home visits.
Yeah, that's a rarity now.
I think that's a rarity compared to the old days.
Yeah.
Anecdotally, talking to some of the older GPs, I think funding was much better in the times gone by to fund. Medicare would pay a higher remuneration for after hours visits or home visits. And also,
they still do. It's just that they still fund higher rebate for those things, but it's just that the rebate has not kept up with the times.
Compared to in the past and in inflation.
Yeah. So it's just not kept up with the times.
Yeah.
So that's why it makes no sense to do it, and you rather the patient come to you. But then at the same time, there's so many avenues where we need doctors for, even if it's like just a hair loss clinic, there's tons and tons of cannabis prescribers.
Yep.
I'm not going to go into the validity of that, but there's also, weight loss clinics that do a lot of telehealth prescribing, and those need GPs as well, or they need other forms of doctors. Where are we pulling these doctors out of? And as in, is there an opportunity cost to taking these doctors away from traditional GP work, or is traditional GP work just not attractive enough? So that's why everyone's flowing onto that.
Yep, that's the $1 million question.
Is that? So you're going to tell me the answer to that. And so where do you see sort of GP heading down, as a profession, or shall we bring back the good old days where you didn't need to go down, say, RSC GP training or ACRM training to do some of the general practice work? Before, and this was like something like 30 years ago, anyone could be a general practitioner, but perhaps not a family physician. What do you think?
Yeah, this is a very tricky question. I think I'll go back onto what I said earlier. Like it's hard to see the future, but I foresee, there will be, and I think a lot of the medicine will, I think, become more personalized or cater to what the patient wants, right? Like some patients will want a longer consult with a regular general practitioner or at least a general practice clinic, and they might be willing and able to pay a gap fee.
Yeah.
But there may be a place for bulk billing clinics or government funded clinics where it can look after the less fortunate of society as well. And then there's also some patients maybe have less chronic disease and they just don't see the value in having to come in face to face to see the doctor. The convenience of a script through telehealth. So I think medicine and technology, and I know you work a lot and in the technology space. I think AI is also another big question mark, and see how that will change medicine. I think there'll probably be lots of different forms of primary care or first line medicine in the future,
or one that's not even delivered by a doctor, because we're seeing scope creep by a lot of other professions as well. I mean,
pharmacists prescribing or nurse practitioners prescribing also on the online social media is a very touchy topic and a very controversial topic. And so there's
also lots of other, professions trying to get in, as you said, nurse practitioners and pharmacists even delivering some degree of primary care. But at the end of the day, it's really, primary care is getting more and more fragmented, isn't it? Rather than more holistic.
A lot of older GPs have quietly voiced that they feel, general practice is on the decline or fragmenting. I guess it's very difficult to say because I don't want to actively discourage people from considering general practice as well. I think there will be opportunities for doctors. Perhaps in the future might not need as many GPs per 100,000 of population, etc. Perhaps with AI, artificial intelligence, or perhaps with multidisciplinary team might be able to kind of make GPs more efficient in a way. So I guess that's maybe one more optimistic way of looking at it.
Yeah, or we just need to fundamentally rebrand general practice into the different individual components, because a GP is an urgent care doctor, a GP is a nursing home doctor, a GP is a family doctor, a GP is a telehealth prescriber for a cannabis business, right? I mean, there's just so many hats you're wearing. I don't think it can still be described as one, one label. And perhaps the way to go about it is to just have a complete rebrand and say, these are the doctors that are going to do family practice, which is what, in the US, they call it family physicians, where you become you're a GP for the entire family, cradle to grave, all that nice thing, you're specialist in life and all that sort of thing where traditional general practice is. And then we need to also find people who are willing to go into nursing homes and perhaps just do nursing homes. And that sort of training has nothing to do with the office style general practice, right? Because that's more general medicine, more almost geriatric medicine or rehabilitation medicine. And perhaps we need to train up a whole cohort of doctors that currently do not exist to just do that, rather than pulling from the traditional or family practice GP type. Yeah. And then obviously there's urgent care. We're so siloed. And because of the way in Australia, we are sort of almost siloed by specialty because of Medicare, there's all these sort of artificial barriers for fluidity between them. Because, I'm an emergency doctor. If I wanted to go into nursing homes, I can't, because I don't have your item numbers. Whereas would I do a worse job? Maybe, but maybe not. And there could be people who are, BPT trainees who want to also do that from a general medicine perspective, but they never finish BPT training, or they've never finished advanced training. Yes. They might want to do nursing home medicine, but there's no avenue for those people to go. So maybe we need to redesign primary care in a completely different way. Yeah. That's my personal thought. But maybe I'm just can general practice do it all? That's the question, right? Is there enough people coming through? Yep. And is there enough capacity in the system? Or do we just have to import tons and tons of people from overseas? And then that creates its own problem. I
read somewhere also that Australia might not necessarily have a GP workforce shortage, but might have a distribution issue. A lot of GPs work in metro areas, while rural Australia find it hard to attract GPs to work there. Could be distance,
there's a
professional isolation, and also, it's also interesting pay as well. You can see in the mining sector, fly and fly workers, they can pay, double, triple to attract people to work those roles, whilst, Medicare, there's not much, maybe a slight incentive, but not a sizable enough incentive to attract doctors to work in these rural, remote areas.
Yeah. I mean, the bulk bill incentive is a little bit more, but that's chump change to the sacrifices you have to make.
Yeah. What are your thoughts on artificial intelligence or AI and kind of medicine and primary care?
Well, I think that's a good question. I think AI will eventually change the landscape of that, and perhaps it will become a triaging tool or a middle layer between it. And we're gonna eventually create sort of two systems. Right? One system is the people that can't afford you or I, and they will just have to have a machine behind doing all of that stuff. And if your care is not great, then it's tough luck, because that's all you can afford.
Right.
And And then you have a more sort of concierge service where you have all these technology enabled and you have a person behind it. I think that's where it's going to end up in, not immediately, but in 10, 20 years. That's probably what's going to happen. You have a person behind it all. Or you get to a stage where you have a lot more sort of mid-level people in between the technology layer and the individual physician layer. And so this is why I say, when I say, let the alternative providers come in, right? And what we need to do as a profession, we need to differentiate that medical-led care is superior to all the other led care, either through outcomes or through connection or through some other means. And so it actually strengthens our case why we do a better job. Because I know a pharmacist is not going to do a better job at prescribing antibiotics for UTI. Might be convenient, but you're not getting the best care you can.
I mean, that's the government's argument. It's so hard to get into GPs. Therefore, we need pharmacists and nurse practitioners.
And that's fine. Let them go do about it. Let them fail. Let them come back and we will pick up the complications. And if that's the kind of healthcare system we want as a society, right? Because the government is saying that, let it happen. But what we need to do as a profession is that we need to make ourselves so good that what we can offer is unassailable, right? Let them prescribe their antibiotics for, for the UTIs or the cold and flu, and let them do that, right? That's not like, yes, it might be financially worthwhile for you to see a patient in 5 minutes because they've got a cough and cold, and it's like, yeah, that's fine. You don't need antibiotics, rest and care. And that's like low value care. I call that low value care. All right. Let the other providers deal with the low value care. We provide the high value care, and we can then justify, perhaps better funding or better pay for that. Right. I don't see a need to basically legislate against pharmacists prescribing. If they want to do that, fine. Maybe they should let us dispense medications, right? But look, that's a pharmacy guild. That's a pharmacy guild.
Well, it's interesting. Some of the pharmacists I've talked to, they don't necessarily want to.
Well, the pharmacists don't want to do that because that's additional risk for them.
And risk.
That's additional risk for them. And the question that remains unanswered is that with the Queensland trial, there's been a number of adverse events that's been picked up from that trial. And the question is ultimately who's liable for it? Is it going to be the pharmacist that's liable for misdiagnosis? There's been STIs that's been misdiagnosed as UTIs. There's been all sorts of things, right? And what happens when there's complication? What happens when there's adverse events, right? Who's there to deal with them? Of course, that's us, right? That's us doctors or the hospital system that deals with it. But what that means is that it's clear that we are the last line of defense, and that's what we're there for, right? If other people want to do silly things, let them go, let them fail, and then we'll be there to pick up the pieces, I guess. And then it's the patients, it's the society that asks the question, where do all the value lie? And let them select. Because we have so much demand. What you're saying, we can't even get into a GP for weeks. It's like, okay, if you can't get into GP for weeks, we're not in short, we're very short in supply. So you can then dictate the market in what you want to do, how you want to practice. And I think that's the key. We're still trying to practice socialized medicine when the socialized medicine funding model is not working anymore. And
well put.
I think that's the issue. And look, I might be completely wrong because I'm seeing it as a third party, but I've been following all this stuff very closely. And if the government does not want to fund a system that they believe in, we can pivot. I mean, do we want to go to a US model? I don't think anyone of us wants to. But if that is what the economics and the funding is doing, that will generate its own thing. And we as a profession, unfortunately, we are still led by where the dollar and cents are. We can't do any of this without money. And so it's why we need to also invest in our profession and safeguard our profession for the future generations of doctors, and not just, and fight the battles that are worthwhile fighting, because there are some battles that we're never going to win, right? Because there's, big PE players with lots of lobbying money. There could be lobby groups such as the Pharmacy Guild, and by the way, they don't represent pharmacists, they represent pharmacy owners. So that's a commercial lobbying group, right? And very much in the same way, like, big oil, big gas, big minerals lobby the government. They do so because there's an outcome from it, and there is a dollar and cents behind it. I just find it very funny that we trying to, when I talk of say we, I mean we as a profession and all of our various craft groups, we don't play the same game that all these other guys are doing. We don't lobby the government. I mean, we lobby the government with common sense and, our superior intellect, but we lose every single time because there's a financial incentive behind the other guys. Who's going to win? We're taking knives to a gunfight. That's my rant. What do you think? Criticisms, critiques. Do you always find that we are fighting against this enemy that just always outguns us, outmaneuvers us all the time?
I mean, it is interesting because obviously, doctors and healthcare professionals, we want the best outcomes for our patients.
Absolutely.
Ultimately, if this alternative model that the government proposes leads to better care, then should be all for it. But we need to do more kind of studies and research onto that. And then on a different topic, obviously it's been topical in the last few years or last year or so about healthcare workers and pay and strike. Obviously striking often is a is last resort kind of thing, but often unlike other professions like say train drivers for example, they can or stop working all at the same time.
Nobody does.
But obviously doctors and nurses, because we care so much about the patient, we still have skeleton staff, and obviously
there's a safety component into it, right?
But I think a lot of the times perhaps sometimes government might be taking nurses and doctors
taking the piss and taking advantage,
taking their goodwill for granted. But obviously hopefully the government will see the value that the hardworking doctors and nurses do. Otherwise, I can see also talking to some colleagues, some doctors, some nurses have left for other things, and
they left other states because
or other states.
It's a very New South Wales problem because New South Wales is underpaying its doctors and nurses. So
because also doctors and nurses, yes, doctors generally tend to be higher paid, but not all doctors, right? Not every doctor is a surgeon or anesthetist, and with they're talking about in the media about cost of living crisis, that also, doctors, nurses are also human as well, have families and school bills and mortgages and their own health problems or healthcare costs, it's very hard to work for free.
Yeah. And that's, nobody is really working for free, but if it starts to feel like you're not being valued in the system, and, whereas some big corporate can just come in and extract tons and tons of profit through lobbying for either funding or for incentives or for exploration rights and all these sort of things, and get away with it. Yeah, it's discouraging, from this side, because when I first came to Australia, there was a land of opportunity, right. And I'm just seeing that the opportunities are perhaps getting less and less and less, and it's I think politics has a lot to play with it, and the government hasn't always done, made the right calls, but it is what it is. That's the system and the rules that we've been put into. And if you have a particular kind of rules, you're going to get a particular kind of outcomes. And unless someone has the fortitude to change the rules, and in our situation, that's the funding mechanisms, perhaps Medicare, perhaps what it means to be a general practitioner, right? That's going to be a very, very different outcome if we can change some of those rules.
Yeah, I think there's a saying, we're trying the best we can in a broken system, Or
the framework you've been given. Yeah. I'll give you another example, because I do a bit of dental sedation work, and dental sedation used to be done predominantly by GPs.
Right.
Yeah. But now nobody's doing that anymore, because The people who are predominantly doing that used to be all grandfathered in, and they can't access Medicare anymore. So they've lost that. Most GP anesthetists are not can't do any anesthetic work in the city, and so they don't have the experience anymore. They can't get any jobs, so they're not doing any of that. And even in the rural areas where GPA is still a thing, that's the only places they can work. There's very few facilities that will allow accredit a GP anesthetist to do anything, right? And so you're seeing narrowing of the scope, and it's getting narrower and narrower and narrower compared to what the GPs of old used to do.
Yes.
But then we still need those guys because those guys fill in particular niches. So what they've done now is that they brought in dental sedationists who have very minimal airway training,
right,
who have, never done any sort of medical work to give sedation to dental patients. So that's what's happened. If we as a profession do not give the scope for our profession to fill in those gaps, someone else is going to come in and take it. It's just like, okay, if we don't want to do the low value care work, then the nurse pracs, the telehealth companies, and the pharmacists are going to fill that void. That's the natural progression of things, because there's still a demand. Well, it's a problem. I don't think we've come up with any solutions. Have we?
just a chat today.
This is a chat about all the problems and where we think things are heading. But I'm still bullish about the profession. I think we probably just need to redesign and rebrand what we do and what it means to be a doctor.
Yeah.
With that somber note, thank you for coming in.
Yeah. Thank you, B. Thank you for having me.
This podcast is for educational and entertainment purposes only. The information and opinions shared are not intended as personal financial advice. The content presented should not be relied upon for making financial, investment, or other decisions. Listeners are strongly encouraged to seek the advice of qualified financial or legal professionals before making any financial decisions. While we aim to provide valuable and accurate information, we make no guarantees regarding the completeness or accuracy of the content. Any reliance on the information provided is done at your own risk.